How to classify anemia because of the clinical approach, okay, or according to the clinical approach. What do you mean by clinical approach? When you have taken the history, when you have done physical examination, okay, or you have done some investigation, what is the diagnosis? What type of anemia is this according to my history and physical examination mostly? This is known as clinical approach to a child with anemia. So this is very, very important when you start working in the hospital. There is anemia, and along with that, okay, if there are no lymph node enlargement and no hepatosplenomegaly, means enlargement of the liver and spleens are absent and there is no lymphadenopathy, then we think of these disorders as the cause of anemia. Now again, we divide them into two parts: no petechia or ecchymosis and with petechia or ecchymosis. Now what is petechia and what is ecchymosis? Yes? Anyone?
Septicemia is the purple red
Sir,
spots on the skin, and the ecchymosis is the discoloration of the skin resulting from bleeding underneath, typically caused by bruising.
Okay. Now,
sir,
yes, please, please.
sir, PTK is a pinpoint bruising and pinpoint spots, but in ecchymosis like bruising type of discoloration on the skin.
You don't want any bleeding mainly, sir.
Okay. Now, see there, you already got the concept. Very good. So, petechia means the smallest type of hemorrhage. Smallest means pinpoint, hemorrhage or bleeding on the skin is called petechia. Ecchymosis means it bruise-like appearance. Very good. Bruise-like appearance means they are blue. They are blue patches. They are much larger, okay, in size. They are ecchymosis. Both of these are disorders, okay, we seen in bleeding or clotting problem. Now, iron deficiency or megaloblastic anemia, pure red cell aplasia, which is also known as diamond black fan anemia. Diamond black fan anemia is known as pure red cell aplasia. Thalassemia trait is the carrier state of thalassemia. Trait is called carrier state. RBC enzyme deficiency, like G6PD deficiency, you can easily include it here. Lead poisoning, lead is a heavy metal, and renal disease or renal failure. All of these, okay, will cause anemia without lymphadenopathy, without hepatosplenomegaly, and no bleeding disorder. See there? Now it is easy for us. But at the same time, if there is petechia or ecchymosis present, but there is no lymphadenopathy and no hepatosplenomegaly, we think of these conditions. Okay, these are important one. So let me underline them. Aplastic anemia, where bone marrow is aplastic or hypoplastic, it is not producing enough cells. Bleeding disorders, okay, like ITP. Coagulation disorders like hemophilia, okay, it is again written ITP here. We can add leukemia here also. Leukemia is also a type of bleeding disorder. And DIC, disseminated intravascular coagulation. Some of the disorders are in the different group, okay, because of their different mechanism. Now, if a child presents with anemia with hepatosplenomegaly, we think of thalassemia. This is a thalassemia measure. Okay, this is a thalassemia trait. Here is thalassemia measure. Hemoglobinopathies, okay, like sickle cell anemia and liver disorder. Now, in sickle cell anemia, splenomegaly occurs only in the early phases. In the late phases, there is destruction of the spleen, which is known as autosplenectomy. So we cannot find splenomegaly there. Okay, and liver disorder usually results in both hepatosplenomegaly. Splenomegaly occurs because of portal hypertension in case of liver disease. You already know that. Now, the final is with petechia, lymphadenopathy, and hepatosplenomegaly. All of the things together. See this. There are bleeding spot on the skin, enlargement of the lymph node, and enlargement of the liver and spleen. These occur very commonly in leukemia. These are hematological malignancy. Myeloproliferative disorder, okay, myeloproliferative disorder. There are 4 different types. We'll talk about that towards the end of our hematology discussion. One of the important type you can remember now is chronic myeloid leukemia, CML. Chronic myeloid leukemia, CML. Infection and infiltrative disorder like lipid storage disorders. Gaucher disease and Niemann-Pick disease can be written here. So this may be a little bit difficult for you at this stage, but trust me, if you study like this, when you start working in the pediatric hospital or pediatric center or any hematology center, you you will reach to the diagnosis in no time. Okay, this is a very good approach. Let's move on. Now, what are the general investigation we like to do in a case of anemia? And this is a general investigation, okay? Now, see there. First, we always start with complete blood count, CBC. This is hematology we are talking about, so CBC has to be done first. And under CBC, these are the different things. Here, RBC count, RBC indices, WBC count, platelet count, and peripheral smear. Though you have to order peripheral smear separately, but these are very related with each other, so we are talking it together. So RBC count will be ordered, and along with that, what is the hemoglobin level, what is the hematocrit level, and what is the reticulocyte count. We order everything. Okay, so I don't need any, I don't need to give any explanation here. Okay, you already know. Now, one small question I like to ask: why reticulocyte count is done? Why? What is the purpose of doing this? Anyone?
Sir, because when we do the reticulocyte count, because sir, the reticulocyte count give us an info about whether the bone marrow is working properly or not. Because if the reticulocyte count is low, sir, there is a absolute problem in the bone marrow, sir. It is not making the amount of RBC required, sir.
Good, good, very good. Good explanation you have given. Absolutely correct. Now remember, reticulocytes are a bit of premature RBC. So they are produced by bone marrow. So if reticulocyte counts are higher than normal, that means bone marrow is overworking or hyperfunctioning, which is a important feature of hemolytic anemia. Whereas if reticulocyte count is suppressed or lesser than normal, that means bone marrow is suppressed or depressed, or bone marrow is not functioning well. So this is the important information you get by doing reticulocyte count. Other things are quite easy there. Now, regarding the RBC indices, you can go for MCV, okay, mean corpuscular volume, MCH, mean corpuscular hemoglobin, and MCHC, mean corpuscular hemoglobin concentration. These are called RBC indices. And another one is called RDW, red cell distribution width. Now, this is, okay, uh, in one film, okay, in one film under the microscope, what are the sizes of RBC there? Studying, okay, of this particular thing is called RDW, red cell distribution width. So this is a part of a peripheral smear. WBC count we always do. What is the total leukocyte count? What is the differential leukocyte count? And is there any segmentation of neutrophils or not? I mean the excessive segmentation of the neutrophil, hypersegmented neutrophil, which is a part of megaloblastic anemia. Platelet count is routinely done, and peripheral smear is always done as a part of hematological investigation. It gives us important information about cell size, hemoglobin content, which is the color of the RBC. It is color, okay? And isocytosis means different size. Poikilocytosis means different shape, and polychromasia means different color. These are the important terms in peripheral smear. See this? Anisocytosis, different sizes. Poikilocytosis, different shape. Polychromasia, different color. All of these are very important feature of hemolytic anemia because bone marrow is overfunctioning, okay, and that bone marrow is producing cells, and all these cells are coming to the peripheral circulation in a different period of time. So that's why all these features are seen. Let's move on. Now, another important investigation is iron panel study. Iron panel study. Please pay attention. This is a very important concept. See here. Iron panel study comprises of three things: serum iron, TIBC, and serum ferritin. Okay, you can also go for marrow iron stain, but that is not commonly done because we need some invasive procedure for this. You need to go for bone marrow here, and bone marrow aspiration is not that easy thing to do. It is an invasive thing, isn't it? You need a bone marrow needle. You need to prick, okay, into the bone marrow and then aspirate the things, then send to the lab. So if other things are giving us the important, information, why should we go for the invasive test? But if it is necessary, we need to go for it. So serum iron, this is the normal value, 50 to 150 microgram per deciliter. But let me tell you one thing here. Don't need to pressurize yourself to know these normal values. These days, any of the investigation report you see, there is a normal value written on the side. Okay. So as a medical student or as a doctor, what is important for me is interpretation. That is important. Is it normal or abnormal? And what are the conditions when it is abnormal? So this is important. So take this type of knowledge here when we discuss, rather than knowing these normal values. It is important regarding certain common things. For example, what is the hemoglobin value? You should know it. What is the platelet count? You should know it. What is MCV? You should know it. But not these, other things. TIBC is total iron binding capacity, and this is the normal value. See there, sorry, this is the normal value. Now, if TIBC is increased, what does that mean? Anyone?
Iron deficiency anemia, sir, because there is no iron, that's why total iron binding capacity.
Most of the iron has been binded to the transferrin service. So do we say we have less iron?
Okay. Yes.
In the bloodstream, so you will have the iron deficiency anemia mainly.
Good. So both of the answers are absolutely correct. When TIBC is increased, that means it is a case of iron deficiency anemia. The reason is TIBC means it's the capacity of transferrin to bind iron. In case of deficiency of iron, the receptors on the transferrin surface are empty. They can bind more iron if we provide it. That is all about TIBC. So it is increased in iron deficiency condition and it is decreased in iron overload condition. Very important knowledge. Serum ferritin. Ferritin is iron storage form. Okay, iron storage form. So it is naturally decreased in iron deficiency anemia. So see there. So if iron deficiency anemia is my diagnosis, then serum iron is decreased than the normal, TIBC is increased, and serum ferritin is decreased. Along with that, hemoglobin is decreased, hematocrit is decreased, and MCV is also decreased. MCH and MCHC are also decreased. So everything is going down except TIBC, which is increased. So this is a very easy way to remember, okay, the diagnosis of iron deficiency anemia. We'll talk about that in today's class. I've included that as one of the lecture. Now, let's move on. Marrow examination or bone marrow examination is a very important investigation of hematological disorder or anemia. Okay, so there are two types by which we get the marrow. One is aspiration, another is biopsy. There is a difference between these terms. Aspiration means we put a bone marrow needle there and we aspirate the marrow. We don't cut or we don't take any chunk of the tissue from bone marrow. This is aspiration. Means the bone marrow should be cellular, then only something comes out. If bone marrow is already absent there, if the bone marrow, okay, means there is a extensive fibrosis of the bone marrow, there is destruction of the bone marrow, then aspirate will be negative, and during that time I need to go for biopsy. Okay, this is the small difference between the two terms. Now what we do after that, we check for myeloid erythroid ratio. M is myeloid, E is erythroid ratio. Now you all know myeloid means premature cells of myeloid series, and erythroid means premature cells of RBC series. So when we take the ratio, okay, the normal ratio of myeloid erythroid, ratio here is, let me write it here. The normal ratio I'm talking about now is, okay, according to a different textbook, it is from 1.5 to 4, okay, or sometimes even 5. So the concept is important here. Now, what does that mean? If this ratio is increase or decrease, I need to interpret now. So please, listen carefully here. Let me ask certain questions quickly. If ME ratio is increase, what does that mean? That means the myeloid cells are in increased number than the erythroid cells. So in which situation the myeloid cells are increased in bone marrow? Anyone? What is that situation?
Any disease or infection?
Any infection. Very good. Infection is one of them. Absolutely correct answer. Another is myeloid malignancy, hematological malignancy, which involves the myeloid series. Okay.
AML, sir.
AML. Absolutely. AML or CML, you can say. Chronic myeloid leukemia or acute myeloid leukemia. And one more, if erythroid series is suppressed, for example, there is pure red cell aplasia. There is a condition we have already studied before. Pure red cell aplasia. Erythroid series is very suppressed there. So during that time also ME ratio is higher than the normal. Now when ME ratio is decreased than the normal, that means bone marrow is suppressed, okay, like in aplastic anemia, like marrow infiltration by different cancers and even myelofibrosis. So these are the concept. We check for morphology, okay, or cell morphology inside the bone marrow, and we do iron staining of the bone marrow. This iron staining is one of the investigation of iron deficiency anemia. And iron stain is done by Prussian blue stain. Okay, Prussian blue stain. Now, regarding the biopsy, we check for cellularity of the bone marrow and morphology of the cells. Similar type of things. Sometimes there may be blast cells present when we check the bone marrow, and blast cells are the hallmark of hematological malignancy. So this is the meaning. Now, let's move on. Another important part of investigation is called Coombs test and the antibody screen. Now this Coombs test and antibody screen will identify, okay, certain abnormal antibody, and if they are present, that means this is autoimmune hemolytic anemia. Autoimmune hemolytic anemia. Now there are two types of Coombs test which we do. The first is called indirect Coombs test. Okay, indirect Coombs test, where we only identify the antibody. Okay, only antibody. Antibodies are present in the circulation. That means indirect Coombs test is positive. Whereas direct Coombs test means those antibody are fixed. Okay, the antibody are fixed on the surface of the RBC. On the surface of RBC. See there. Now, please pay attention here. This is a very important concept for us. So let me make it a bit bigger for you so that it will be easy. See this. So in case of hemolytic disease of the newborn, also known as RH incompatibility, okay, there is a maternal antibody which is present in the fetal circulation. If we do, okay, indirect Coombs test on the mother, and if we detect that antibody, okay, this means the antibody is already present, so indirect Coombs test is positive there. Anyone? Okay, I'm sorry for the a bit of disturbance. Now, can you see the slides? Yes, guys?
Yes, sir.
Yes,
sir.
Yeah, I think there's a bit of disturbance in the middle. So what I'm talking here is, direct Coombs test. Now, if direct Coombs test is positive, that means those antibody are already fixed on the surface of RBC. So I was giving the example of RS incompatibility here. If the antibody from the mother have already gone onto the fetal circulation, and if they have fixed on the surface of fetal RBC, then direct Coombs test would be positive. That means the RBC are going to be destroyed very soon. So this is the evidence of autoimmune hemolytic anemia. Let's move further. Some other types of investigation which we are going to do is hemoglobinopathy. Okay, hemoglobinopathy. See this. Now, what is hemoglobinopathy? There are some abnormal hemoglobin present on the blood, and that can be diagnosed by hemoglobin electrophoresis or quantitative hemoglobin A2 or detection of hemoglobin F. Now, let me clarify this for you. The different examples here are sickle cell anemia and thalassemia. Now, sickle cell anemia and thalassemia are very easily diagnosed by hemoglobin electrophoresis. This is a very important test there. HbS is diagnosed in sickle cell anemia, whereas if this is a case of thalassemia, then hemoglobin F is in very increased level and hemoglobin A2 is also higher than the normal. Because thalassemia, we are talking about beta thalassemia measure now, so there is no synthesis of hemoglobin A. So the hemoglobin is diverted towards hemoglobin F synthesis. So that's why there is an increased level of hemoglobin F. And similar type of explanation I can give for hemoglobin A2 also. Okay, we are going to talk about thalassemia, and during that class we'll talk in detail regarding this. Now, lead study is the another one. If you think this is a lead poisoning, just go for the serum lead level or go for free erythrocyte protoporphyrin. Okay, this protoporphyrin is a metabolite of heme. Okay, so free erythrocyte protoporphyrin is increased in case of a lead poisoning. Membrane defect test is done by osmotic fragility test. Now, just remember, this test is connected with hereditary spherocytosis disease. What type of disorder is hereditary spherocytosis? What type of anemia is this? Yes? What type? Just give me the type of anemia. You don't know in detail regarding this because we have not talked. But what type of anemia is this? Is it iron deficiency anemia or microcytic hypochromic anemia? Okay? Or is it hemolytic anemia? What is the answer?
Hemolytic anemia,
It's related hemolytic anemia.
Hemolytic anemia, sir.
Excellent. This is a type of hemolytic anemia where there is a deficiency of the membrane protein on the surface of RBC. Now, because of this, okay, because of this problem, those RBC can be broken or can be hemolyzed or destroyed very easily if we dilute the normal saline and do this test. This is known as osmotic fragility test. Means the RBC in case of hereditary spherocytosis are more fragile than the normal RBC. This is how you should understand. So this is an important MCQ question. Osmotic fragility test is positive in hereditary spherocytosis. Now, enzyme defect, we can go for these different types of enzyme analysis now. This is known as quantitative enzyme assay, and a good example is G6PD deficiency, where G6PD level is very low than the normal. And if we believe vitamin B12 or folic acid deficiency anemia is there, just go for the evaluation of that, the level. And if they are decreased than the normal, then your diagnosis is confirmed. Let's move on. Now, with this, before we go for the discussion of iron deficiency anemia, one of the very important concept I like to, bring in front of you, that is physiological anemia of infancy. Now, first of all, what is infantile age? What do you mean by infantile age? Yes?
From the date of birth to 28 days.
Are you sure that is infant? That is neonate. That is
No, sir,
neonate.
From birth to 1 year.
But to 1
From
year,
birth
sir.
to 1 year.
Exactly. From birth till 1 year, okay? Birth till 1 year is called infant. Now see that. Usually these, small babies, they are having anemia, and that is called physiological anemia of infancy. Now, what is the mechanism for that, and what is the time when they develop this physiological anemia? Let's talk about it. It is a physiological adaptation to extrauterine life. After the birth of the baby, they have to adapt to that extrauterine life, and this is one of the adaptation mechanism. Okay, now see here, there is a very high hemoglobin level, around 13 to 20 gram per deciliter. We already talked about this in the previous classes in the normal newborn, which progressively decline when the baby becomes, bigger, due to following reason. Before I go to this reason, let me explain why it is more. In the intrauterine life, okay, the hemoglobin and the RBC, count, hemoglobin level and RBC count are much higher than the normal, because that, period is considered relatively hypoxic period for that baby. So to compensate for that hypoxic, environment, hemoglobin level is higher. So please understand like this. But after the birth, the baby is taking breathing. Okay, the baby is having more oxygen in the lung. That oxygen, okay, is transferred to the blood. So more oxygen is available for binding to hemoglobin. So the baby doesn't need so high hemoglobin or RBC count. Another point, fetal hemoglobin is replaced by adult hemoglobin. So more oxygen is available for the tissues. That is a big difference between fetal hemoglobin and adult hemoglobin. Fetal hemoglobin will bind to the oxygen very readily, but it doesn't give the oxygen to the tissues. Whereas adult hemoglobin will readily give the oxygen to the tissue. And after the birth, slowly fetal hemoglobin is replaced by adult hemoglobin. After 6 months, the percentage of fetal hemoglobin is around 1%, or in some of the textbook it is written less than 5%. More than 95% of the hemoglobin after 6 months is adult hemoglobin. So what does that mean? It is slowly replaced by adult hemoglobin, and this is good for the baby, because adult hemoglobin has a huge advantage over fetal hemoglobin. Another point, there is down regulation of erythropoietin production. And erythropoietin is the hormone which stimulates bone marrow for the more synthesis of RBC. So because of these three important reasons, the hemoglobin progressively decline, okay? And by 8 to 12 weeks of age, it may reach around 9 to 11 gram per deciliter. This is known as physiological anemia of infancy. See this? It may reach up to 9. And according to the definition, this is anemia. But we don't need to worry much about this anemia. That's why the term physiological, the baby will recover in time regarding this. So no treatment is required for this. Okay, but if you do not know what is this condition all about, then you may go for different investigation, you may go for different treatment. This is not good for that small baby. Hypoxia is detected by renal and or hepatic sensors. Erythropoietin production increases after that, and RBC production resumes. Then slowly it will come back to the normal. So what does that mean? After the baby develops anemia like this, anemia, okay, will cause decreased oxygenation of the tissue, and that sensors will detect that hypoxia. Now after that, again erythropoietin is increasingly produced and RBC production resume,